Hello, and welcome to the AANMC webinar on women and heart disease. Today, we are honored to have with us Dr. Decker Weiss. Dr. Weiss became the first cardiologist as a naturopathic physician, completing a non-invasive cardiovascular hospital-based training in the Columbia Hospital System, the Arizona Heart Institute, and the Arizona Heart Hospital. He went on to become a fellow of the American Association of Angiology. Dr. Weiss kept privileges at the Arizona Heart Hospital for a decade while opening a breakthrough Scottsdale Heart Institute where he helped thousands of patients reduce or eliminate medications safely, as well as eliminate the need for angioplasty, ablation, and bypass surgery by reversing heart disease and managing arrhythmias naturally. The International Association of Healthcare Practitioners and the International Association of Cardiologists named Dr. Weiss a leading physician in the world in 2012, a distinction given to under 1,000 physicians each year. Dr. Weiss maintains a teaching-based practice and is a director of Artis Research's Center for Health and Medicine. Dr. Weiss has worked in Haiti, Tibet, and recently on the Syrian border, both in a medical capacity and as a researcher to look at the biochemistry of violent behaviors and radicalization. Dr. Weiss is the author of a best-selling book and has lectured and taught in some of the finest academic and medical institutions in the world, including the Cleveland Clinic. Along with all of this, I count Dr. Weiss a friend and a mentor, and I am so happy to have him with us today. Before we get started and I turn it over to Dr. Weiss, I just want to talk about something technical. We will be having this webinar recorded today, and we'll have it up on our YouTube as well as our website for future viewing. Additionally, during the course of the webinar, all attendees are in mute mode. If you have any questions, you can use the question box in your control panel, and I will try to answer the questions as best I can or turn them over to Dr. Weiss during the Q&A session. If any questions do not get answered during the course of today, please feel free to email any general questions to info@aanmc.org. That email address will be posted at the end of the webinar as well for you. Thank you very much. And with that, I turn it over to Dr. Weiss. Dr. Weiss, thank you so very much for joining us today. The show's yours.
Thank you. Thanks for having me, everybody. It's a very big privilege to lecture to colleagues, and I don't get to do it very often. And it's funny, I can get up and lecture in front of medical doctors and functional doctors very easily. Around my colleagues, I tend to stumble a little, so bear with me here as we get through this information. I want to start with my first slide here, if I can get this to work okay. Let me see here. And I'd like to dedicate this first to a friend of both mine and Dr. Holly Lucille's, as well as many, many naturopathic physicians, Dr. Marcus Lowe. He was one of the pioneers in women's medicine, actually coining the term and getting the original development going of bioidentical hormones with an eye towards nature cure always, saying that you still want to restore, not replace function. But Marcus was one of our original elders, a great guy, a guy translated all generations in a simple conversation. He's a big loss for everybody. And Marcus, wherever you're at, you know that our thoughts, and we thank you for your work for our profession. We're very, very honored you chose our profession. And we'll move on, and I get to talk about me, and that'll take about a half hour, and then you can go back to throwing up the rest of your lunch after that. But anyway, my background is I went to Western Illinois University. I went to a local college in Arizona called Grand Canyon for biochemistry graduate school. I'm an SENM grad, and then I went on to the Arizona Heart Hospital, Columbia. And now I do a lot of research with refugees, specifically Syrian refugees and now Yazidis and Kurdish refugees in the Iraqi and the Syrian parts of Kurdistan, where I do a lot of work there as well. And I've recently joined the NCNM Global Health Department. That's a very big honor. Very, very smart people there. My weekly routine, I think this is something unique to AANMC. I think that's kind of a neat thing. I'd like to see how the rest of my colleagues spend their time and how crazy it is, because I don't know anybody who's in our profession that has a 40-hour work week, but this is about my breakdown, and I think it's very typical with this. But I got to confess, some of that research and writing is done while there's a TV on in the background, so it's not as altruistic as it looks. Why naturopathic medicine? I was really drawn to the eclectic nature of not just the modalities, but of the people. In my class, I had a lady, Hope Farner. She worked for NASA. And then we had some people who retired and went to med school. We had some people right out of school. all just smart in their really individual own ways, herbalists, master homeopaths. But I also like the lack of prejudice. I find in conventional docs, when they're obstinate to looking at other models of medicine, I find it to not be for any other reason but prejudice. And I know that we excuse that, and that's okay. Everybody has to be ready to do what they're going to do. But I was amazed at the open-mindedness of what's best for the patient. What's the best? Is acupuncture best? Is homeopathy is an adjustment? What is the best thing for this patient right now? And I think we come the closest to choosing our treatment without predetermining it. You're going to get drugs or surgery. That's it. And I think that's the thing I probably enjoy the most, and I'm a little rebellious. Again, that's the people. And I chose to focus on cardiology. Every one of my family has died from cardiovascular disease. And I really wanted to be an integrative doc. I don't really believe that much in integrative medicine. I've never had a patient come to me and say, with my medications, I'd really like to take some herbs on top of that. I really am not much of an integrative guy per se the way I practice. Most of my patients, I try and exit them from the system whenever as possible or as much as possible. Some patients are going to still need diuretics or blood pressure help that for some reason I can't get in control herbally or through detoxing or whatever. But my goal was always to be an integrative physician because I think that's also what the community of patients wants from us. Lots of approaches acceptable, and I really couldn't do worse. I mean, it was the #1 killer of men and women, and you had all this data showing that it was preventable. So I figured I'd throw my hat in the ring. It'd be hard to do worse. I know that that's a bit slighting, but I am a little rebellious. So we'll move on a little bit here. And we'll start with gender inequality, and I'm going to start with my favorite alpha female, just because it's been a long week for us. She's a koi dog. This is Nala, and Nala passed away. She lived mostly outside, but a little bit inside. She's half coyote and half chow, as you can see there. And she laid down and passed on a little bit. But she's my favorite alpha. And it's funny, when I think of strong women, I do think of my wife and my daughters, but I really think of her because of her true independence. And she was alpha over all the men and female coyotes that were in our area. The men had come and drop a bird for Her Highness. So she handled it well and led them well for many years. So we'll move on with some topics, and we'll move right into heart disease in women. Heart disease kills more women than all cancers combined. 4% of women are diagnosed with breast cancer, where 44% eventually get diagnosed with heart disease. We're going to even link how the treatment of heart disease can cause breast cancer as we go through this today. Even though heart disease has been called man's disease since 1984, more women have actually died from it than men. And the figures get on. Another way, 400,000 women worldwide will die from breast cancer, but 8.6 million women will die from heart disease. And we'll start with inequality right off of the bat. And I'll just say this, and I think I'm okay to say this. Conventional medicine, the way it's set up, is very sexist, and I do believe it's built into a lot of the structure. I don't think that's intended by evil people wanting to hurt women. I think it's a byproduct of the way they developed their system without herbs, without homeopathy, without gender equality being stressed from the beginning, like our profession has tried to do. I'm not as successful as we'd all like, but has tried to do. But in the world of chauvinism and sexism in medicine, cardiology is still by far the worst. It's not even close. And when you look at these numbers, you're going to gag a little bit. And what it lets you know is don't rely on cardiologists to heal your women patients. We're going to have to take this over. And we're going to have to do it better. And hopefully what I show you today is going to give you an opportunity to do that. Only 24% of participants in all related studies for heart are women. And largely the reason why is because they said women's menstrual cycles interfered with the research. It's just ridiculous. For 50 years, women have been treated based on diagnostics created for men. So we don't know what's going to really work in women. Surveys of available data show that a very small percentage of research dollars spent in the United States focus on treatment of women. It's mostly, again, male-dominated. And now there's more of a gender diagnosis and care. Heart attacks are more severe in women than men. In the first year after a heart attack, women are more than 50% likely to die than are men. In the first 6 years after a heart attack, women are twice as likely to have a second heart attack. We now know that cardiovascular disease affects more women than men, and we kind of covered that. But at the end of this, premenopausally, women's heart risk is 1 in 7, postmenopause is 1 in 3. And boy, when does that happen? Does that happen during the hysterectomy surgery? Does that happen in perimenopause? I mean, that's a pretty broad statistics and very, very non-defined as far as ages and as far as anything like that. I mean, and what does this mean for these 35-year-old women that are perimenopausal? Did they shoot their risk up to 1 in 3? I think they have. And we're seeing, heart attacks coming down in age with women just like men. Now, heart attack symptoms, I'm not going to go all through this because it's a waste of my time. This is posted as of 2015. Now, I want you to pay attention to the years. Now, this is the American Heart Association's posting on women heart attack symptoms. I forgot to put that on the header there, but this is for women. If you look at this, it's incorrect. It's medically incorrect. Now, Mayo, again, this is posted 2015, about the same time. They're a little bit closer. An abrupt change in how you feel, extreme unusual fatigue, restlessness, insomnia, anxiety. You're going to hear a repeated theme through this lecture: mood, fatigue, insomnia. Your mood, fatigue, insomnia. You're going to hear it over and over if I'm doing my job, because those are the hallmarks that we have to look for. Now, I want you to, I'm going to actually go ahead one slide and then go back. Look at this here. This is 2003, posted in Circulation. This is a self-study. This is conventional to conventional. Top heart attack symptoms in women: fatigue, sleep disturbance, indigestion, heart racing, arms weak and heavy, anxiety, mood, fatigue, insomnia, things like that. During a heart attack, you still have the unusual fatigue. Notice there's no chest pain. There's none of that there. This was done after years of looking at data, done quite well. I think that the paper was outstanding. It is one of these papers that I always have within reach of me to do this. But 2003, this was posted. If I go back a little bit, 2015, the American Heart Association is getting it wrong. As with men, women's most common heart attack symptom is chest pain or discomfort. This isn't true. This is absolutely not true. Mayo tried a little bit better in 2015. So what does that basically say? That says, when we're here, that even though this data has been uncovered, it hasn't been applied. Let me repeat that. Even though this data has been uncovered, it hasn't been applied, it hasn't been taught, it sure isn't being educated to the public. That really bothers me. As somebody with 2 daughters, a wife, that really bothers me. As somebody whose mother had heart disease, again, it really bothers me. If we look at another self-study, now I'm not for treating women the same as men, but again, this is a self-study about, is conventional medicine even able to give their best effort to women, right? I mean, are they able to do that? 14% less women get aspirin a day. I'm not an aspirin a day advocate, but in their system, 14% less get an aspirin a day, 10% less likely to get beta blockers. Now, this is the shocking one. 25% of the women are less likely to receive reperfusion therapy. This means they're in a hospital, they're diagnosed heart attack, and they're not getting clot-busting medicines, blood-thinning medicines to save their life. 25% of the time. It's appalling. Again, American Heart Association self-study. 13% less likely to receive angioplasty, and so on. There's a huge gap. And what this is also saying in these statistics is it's not getting better. In fact, I would argue, since that original data was uncovered in 2003, that it's getting worse, because they're not even paying attention to their self-studies. Here's the experts. The predictive value of current screening tools in women is poor, says Leslie Cho. She's head of preventative cardiology at Cleveland Clinic. The problem was, I mean, this was in New York Times' Parade magazine. That's a big thing. This was Cleveland Clinic. Through the whole article, she complained, but there was no solution offered. It's like watching a presidential debate. Yes, I just said that. I'm not picking a party, okay? But I'm saying, isn't it nuts that there's no solution offered? It's just more complaints. I'd like to get my name in the paper for just complaining. I'd like to think that I would only get my name in the paper for offering solutions as well. Now, worried about cholesterol. Let's look at cholesterol in women, and I'm going to try and this can be a big topic. I'm going to kind of show you what I think is the lead important thing, but please, I know everybody out there probably knows as much or more about cholesterol than I do, but I'm going to show you some compelling things. First of all, cholesterol. There are no ranges. Okay, so when a patient says, I just got my LDL under 100. Okay, good for you, but that doesn't mean anything. So the American Heart Association, an expert panel, evaluated all the available published evidence and found there was no good evidence to support current target levels of LDL. Okay? Now, yes, this is the same paper that came out and doubled the amount of people that were eligible to take statins. But that was not based in science. That was based in opinion. This was the science. This is 2013. There are no cholesterol ranges. The reason they did this was liability, because if a doctor now lowers cholesterol and they come back with cancer, cognitive dysfunction, they were starting to sue their cardiologist. Now the American Heart Association says, look, you can't sue us. See, we didn't say there's ranges. That was up to your cardiologist. It is strictly for liability purposes, but it was based on overwhelming data. So when somebody says my ranges are this, isn't that good? No, there's no evidence to support that. Menopause and cholesterol. We know that the lipid profile is adversely changed in postmenopause. Generally, the LDL and the HDL go up postmenopausally. Both of those things do. But what's interesting is, and this came out of the National Institutes of Aging, what we have done is link the carriers of cholesterol to being the problem. The apolipoprotein B, the apolipoprotein A, not the cholesterol, but the carriers, specifically apolipoprotein B, which is the vulnerable part of cholesterol to oxidize. That seems to go up in this. So let's look at what we studied with cholesterol carriers, okay? ApoB, ApoA1 ratio. I think personally this is the most important lipid marker next to the actual oxidized cholesterol marker. This is the strongest predictor other than oxidized cholesterol. It's based on all available evidence. When you look at this, ApoB, a stronger predictor of than LDL, HDL, statistically best predictor of myocardial infarction. But what happened on the way to doing a good thing with a cholesterol marker? You made it sexist again. The Amoris and the inner heart studies were very, very clear. There were different ratios for men and women. Yet that never made it to the doctors. This is a cut and paste from Medscape articles. There's nothing hidden about this. Yet I have yet to meet a cardiologist other than myself that uses different ratios for men and women. Please, of course they're different for men and women. Premenopausally, postmenopausally, they're going to be different. We have different hormone needs. But Innerheart and Amoris were two of the largest studies on these carriers, and they were very clear about it, and it didn't make the general news. So what I'd say is verify if your lab is using gender-specific cholesterol levels. It's something I introduced with a company about 1.5 years ago. I did send letters out to every single major lab company asking them to reevaluate these ratios and please adjust them for women. I didn't get a call back. I thought I'd get a call back, but that's not the first time that's happened. But I honestly had to do it out of morality. It's just you keep bumping into these things and unnecessary sickness. And so what I would do is whatever lab you're using, I would make sure that those levels are being changed. One quick note, C-reactive protein is also about 0.5 higher in women than men. It has to do with breast tissue. It's higher in interleukin-6. Interleukin-6 converts to the CRP level. That's kind of an equivalent. It stimulates CRP. So you really need to take a 0.5 off of almost every C-reactive protein in women that you'll see as well. Should women risk lowering cholesterol? Well, one of the main trials that conventional docs talk about is the Jupiter trial, and it didn't work. No significant reduction in heart attacks, strokes, and deaths in women, over 6,000 women. And women who are healthy derive no benefit from statins or lowering cholesterol. Even those women who have established heart disease derive only half the benefit that men do. That is really, really pushing it. But at the end of the day, the Jupiter trial is very clear. There's no benefit for women. And there's loads of other studies. I threw the Jupiter trial out because that seems to be what medical doctors base their ideas on at this point. By the way, lowering cholesterol raises risk of cancer. Having genetically low cholesterol also increases your rate of cancer. The thing about cholesterol is lowering it or having low cholesterol is always guaranteed to increase risk of two things, and that is dementia and cancer. But look at this 10-year data, British Medical Journal, okay? Women taking statins for more than 10 years now. This was statin specific. 83% increased risk for invasive ductal carcinoma, 97% increased risk of invasive lobular carcinoma. I'm asked, I don't use red yeast rice. I don't lower LDLs. I think when LDLs are high, they're either genetic or they're there because they're trying to repair things. I run ox LDLs and I get them down under 30. I run the oxidized LDL. That's my move with it. I don't lower it. But again, this data says that cardiologists are sending them across the hall. Now, when you ask cardiologists this, a lot of them will say a simple statement. It makes my stomach curl a little bit. They say, look, if a woman lives long enough to get breast cancer, we probably did our job. And you hear that consistently in conventional medicine. Ah, boy, I don't think you did your job. But you know, that's why I chose naturopathic medicine. It is not my job for them to die of something I potentially caused. And as long as they didn't die from my little world issue, I did fine. It's just not what it is. I always say to my patients, 85 and functional. That is what I'm trying to do to get you there without cancer, a heart attack, stroke, major trauma, whatever it is. That's my goal, and keep you as functional as possible. That means how I treat them is going to be, very different. Statins are also linked to depression, and it has to do with serotonin receptors, and we're going to go into this quite a bit. And I'm going to buzz through some of these slides a little bit faster to get to the case. Depression in women, mood disorders, fatigue, insomnia, compared to men, twice as likely to develop depression. So what that says is, okay, here's a statement as well. It took the American Heart Association and American College of Cardiology about 10 years late, which can be pretty good for those guys. And I'm on the board of American Heart Association now, so it's and I can say that statement. But depression is an official risk factor for heart attack now. So then, if you go back, compared to women, men are twice as likely to develop. Compared to men, women are twice as likely to develop depression. It's an official risk factor for coronary artery disease and heart attack. But when you looked at the severity of it, it was bigger than smoking. It was huge. A huge, huge risk factor. Now, I brought data, and I lectured at Cleveland Clinic. And this is one reason, again, I'm glad to be lecturing to colleagues. When I lectured at Cleveland Clinic and I made this statement, at the end of it, I said, how many cardiologists in the room are willing to ask their patients how they feel or what their mood is or if they're depressed? And only one doctor raised their hand. And I asked the room why, and they said, it's not our job. I don't know how it's not your job. It's a risk factor now. You ask them, you take their blood pressure, you measure their lipids. What is this block about asking people if they're happy? I know it takes work. I know it's draining and all that stuff, but fortunately, that's what we do. So we've discussed a lot of these inequalities and stuff. Let's move on to mood, fatigue, insomnia. Now, again, if you notice through this whole lecture, I keep saying mood, fatigue, insomnia, that these are risk factors for heart attack, especially for women. But what's the exact link? Let's start with serotonin. Serotonin, obviously, we know that it's linked in some ways to depression. Serotonin's also been linked to fatigue. Now, that's mood and fatigue, and that even could be insomnia. The studies have also shown that serotonin is directly linked to heart attacks and heart disease. Now, the study I put has young folks in it, but what we know is postmenopausally, as serotonin goes down, endothelial function suffers. And we're going to cover that in a serotonin estrogen section that's coming up. Norepinephrine, evidence for involvement in norepinephrine and depression. It's also linked to fibromyalgia, fatigue, as well as cardiac events like heart attack, coronary heart disease. So there you go, depression, then you have mood, fatigue, insomnia, and in this case, fibromyalgia, and then it moves on to heart disease. We're seeing a theme here. Norepinephrine also, by the way, is the master controller of cytokines and inflammation. I'd love to do another lecture just on that, but understand that when we don't restore norepinephrine levels, you will not get most inflammation under control. It's very, very hard. Tyrosine and things like that need to be considered in every pain protocol and inflammatory protocol. We'll look at that in our case. And we use a term called sympathetic drive for that. Then we look at catecholamines like epinephrine, norepinephrine, dopamine. When those things start to run low, serotonin can even be part of it despite it not being a catecholamine. But we have a term for that called sympathetic drive. We'll continue on here. This is a basic neurotransmitter report divided into certain things. This person obviously has an elevated glutamate here. When we look at neurotransmitters, we break them down into calming, And again, we're going to go into a specific case with this in a minute, as well as the stimulatory. Now, this person here, very, very inflamed, high glutamate, high dopamine. Now, dopamine and norepinephrine, they can be made by the immune system while they're inflamed. So these people may have, and this person may have a lot of depression, anxiety from the high glutamate. But even though the norepinephrine's are measuring high, this is a urine test, the norepinephrine may be made peripherally by the immune system to quell inflammation. A lot of these times I still will give tyrosine and methylation to bring up central levels of norepinephrine to get inflammation under control. Again, just throwing ideas out there, but when you see high norepinephrine's and they're very symptomatic, their brain is probably low, but their peripheral nervous system is high. Norepinephrine is an antioxidant that attempts to quench free radicals and help with inflammation. But by the way, this is why a lot of fatigue and depressed people have hypertension. When norepinephrine is released peripherally in an inflamed state, it contracts peripherally. It does it just like Levophed. It contracts peripherally, and this is why a lot of these really, really fatigued people have hypertension. This is also like a deficiency excess syndrome. I'm going to hurt myself if I do anything more in Chinese or Asian medicine, but it kind of reminds me of that as well. So you always want to make sure norepinephrine is looked at and got under control. And when we look at this, this is probably a slide that I think is going to carry me through my next probably 5-8 years of lecturing and research. This biomarker timeline is very, very important. The immune system is always reflected in the nervous system. And so that immune inflammatory system, it will always show up in neurotransmitters, functions, whatever, but it'll generally be much earlier. So if you see there in the initial presentation, asymptomatic, may have some triglycerides or a bad ratio, when you look at their labs will largely be normal other than their neurotransmitters and cytokines at that point. Farther down the road, you see then oxidation. You see dopaks go up, oxidized LDL, 5-HIAA. Then later you see the tissue changes. People think, oh, MPO, CRP, this is immediate risk for heart attack. Well, it can and it can't be, but you have to understand, by the time it gets to tissues, as we know as naturopaths, these disease syndromes have been going on for a long time. And then right after that, that's when you have the endpoint. So when we're measuring for prevention and for labs, we have to go all the way back to access that inflammatory stuff. Again, the inflammation, immune system stuff will be reflected in the neurotransmitters and the cytokines. And I hang around with smart guys like Dr. Dan Rubin. He runs cytokines. He's looking for the pattern, the inflammation, and the cancer. We're starting to get to that core kernel where we can prevent a lot more than just heart disease by doing things correctly. Serotonin, the intima layer. So largely when I teach this, I explain when somebody has menopausal symptoms, when a woman has menopausal symptoms, we know that estrogen isn't the exact problem. Estrogen facilitates the release of serotonin, and they have hot flashes, but you have women who are on estrogens and they're still not cooling off. They're still having other problems. It's because their serotonin's too low. That estrogen-serotonin relationship is what dictates the health of endothelium, the lining of blood vessels, especially postmenopausally. You see here nitrous oxide, relaxation of underlying vascular smooth muscles, depression, heart disease has been both linked when you use the medications. Serotonin's vasodilatory, norepinephrine vasoconstriction. This is the balance that they have to have. But I also look at it another way. When a woman comes in and has mood fatigue and insomnia, I assume endothelial dysfunction. I assume there's probably a serotonin or norepinephrine function or GABA. I assume that those problems are there and that I've got to go and I've got to address those, not just giving them, and I love hawthorn solid extracts. I will give them those things all the time to protect them, but I know I've got to go to the core and restore that serotonin level to protect endothelium. Another simple way to think of it, because I've made it over complex, is that vaginal dryness, it's poor mucosal barrier function, right? Low estrogen. Well, what do you think endothelial dysfunction is? It's a mucosal lining. It's low serotonin, low estrogen. It's the relationship between the two of those. And that's the thing that we have to get back to. And that's the estrogen-serotonin connection. Neuronal synapses, estrogen increases the concentrations of serotonin and norepinephrine and dopamine. We include estradiol may have a fast direct on brain membranes to modify serotonin receptors, blah, blah, blah. But it's this estrogen-serotonin connection. I would argue strongly that we should not be prescribing bioidentical hormones without knowing serotonin, norepinephrine, and GABA levels at minimum. Because when those are restored, you probably will need less hormone, and in my opinion, the hormone will be used safer. But also, unless you restore GABA with progesterone or you restore serotonin with estrogen, you will not get that heart prevention. Why, with all these bioidentical hormones, are we not getting better cardiovascular protection? This is why. Because we're not restoring serotonin, GABA, norepinephrine levels. When we do all of that, you're going to see this disease quickly dissipate. And when we listen to our patients on their symptoms, it'll even be better, because now we can take their symptoms and say, hey, your mood is better, you're sleeping better. Guess what? Your blood vessels are better. Really, really cool stuff. GABA is related to endothelium, and GABA is more related to the progesterone cycle of it. But again, you have vasorelaxation, very similar things, and it may attenuate TNF-alpha as a vasodilator. So it's not just serotonin, but serotonin is the main one. GABA levels and norepinephrine need to be reestablished. So I'll take you through a quick case here. 52-year-old white female. His depression, she just happened to have depression, fatigue, insomnia. She also has joint pain, gas and bloating, low sex drive. She's had 2 stents. She's on 2 miracle medications, lisinopril and atorvastatin, 20 milligrams. Homocysteine high. Now, again, when homocysteine high, most of this crowd I'm speaking to is going to know this better than me, but it's a poor methylation piece. So that's kind of the obvious piece. But always remember that methylation is what allows the formation of a lot of neurotransmitters. So when methylation decreases, you will lose formation of neurotransmitters, you will lose formation and then an increase in homocysteine, and it's lethal. Because not only are you getting a decrease in serotonin, so you're losing that endothelial protection, but then you're damaging the endothelium with the higher homocysteine. It's absolutely lethal. This is the 1 in 7 to 1 in 3 jump. Higher homocysteine, lower serotonin is a death march. I mean, it is a nightmare for hearts. Notice, I didn't talk about cholesterol. I didn't even talk about inflammation. I talked about specifically methylation in that aspect. All of these levels are all low, hormones, thyroid, all that stuff. This was her original neuroadrenal thing, and this is late stage. Flat cortisol curve. The only thing she has as far as sympathetic drive is some glutamate, which should never be the highest one, and even her dopamine is all oxidizing into Dopac, completely flat. No wonder she has all these emotional problems and can't lose weight and all this stuff. The cytokines, now it's legitimate. If you're sitting there saying, Decker, cytokines change all the time. If you go for a run, your cytokines increase. It's absolutely true. What you're looking for, and I use the stimulated cytokines for the record, what you're looking for in cytokines is the inflammation, but all of these cytokines that I have listed here are associated with acute risk of heart attack, plaque rupture, also the protection of blood vessels. Now, IL-10 should be high right now. Now, one thing about this lady, when you go back here, you see her body's not responding to the inflammation. Her cortisol's crashed, right? So she can't respond. Her norepinephrine is low. This woman has all this inflammation. Her body cannot answer. But her cytokines here are telling you the same thing. Interleukin-10 is fire, is water on a fire. So ideally, what you want with the cytokine system is for it to not be activated, for all of it to be normal. There's a confusion there that interleukin-10 you want high. No. Interleukin-10 means that you have a fire and you're trying to put it out. Interleukin-10 here should be high with all of this inflammation. It should be very, very high, trying to put down the inflammation. This is another example that this lady can't cope. She cannot meet the demands of her environment. Her body has given up fighting the inflammation. Stents, depression, all of these things. So not only do these things have to come down, but the interleukin-10 has to re-engage and try and put out the fire. Interleukin-8, by the way, being very high is a very, very acute risk for heart attack, so I'm extremely worried about this woman. High-dose natural anti-inflammatories, antioxidants. I did the sympathetic support. Now, boy, here I am a cardiologist. I'm going to raise norepinephrine. I'm going to methylate. I'm going to, it's a liability out there because, people are going to be like, you're going to attempt to raise norepinephrine? And well, of course I am. You wouldn't hesitate to give her Wellbutrin. You wouldn't hesitate to recycle norepinephrine. I just want her to make a little bit more on her own and reestablish control over inflammation. Put her on, I love licorice solid extract. Thyroid, quarter grain waking, a vegan diet with juicing. These folks, I just love the 3-4 week juice fast because that really helps get the serotonin production in their gut up, the glutamate production in their gut down, exercises, vibration table, rebounder, methylcobalamin plus dissonant methylation support, and I stopped the atorvastatin, which she knew within 48 hours how much better she already felt when she went off of that. Step 2, this is 30 days later. Her depression is resolved, but there's still some anxiety, 15 pounds less. Blood sugar fasting to 110, that normalized. BP normalized. Vaginal dryness improved. Lost 1.5 inches in the waist. BP drops out. Lisinopril, I already said that. And so I reran the testing, and here's what we found. Look at a beautiful serotonin level now. Also, see that glutamate being high there? That's why she has the anxiety, because she has that. The dopac's still a little bit high. Dopac's always present, dopac being the oxidized metabolite of dopamine, but it should never be higher than the actual dopamine. So we still have some work to do. Her norepi's coming up nicely. Now, again, when you juice fast them with the things you do, you get a rapid improvement. But look at that adrenal curve. I mean, she went from, if I go back here, flat to here in 30 days. Phenomenal. I mean, she felt so good. And again, the methylation is going to bring up the other function of the adrenal, the norepinephrine production too, as well. So we came at it from multiple angles. Definitely not cured, but my God, she's in the game. And then look at this. Her cytokines round 2, all normalized, and her interleukin 10 came right down into normal as well. Now, interleukin 17 was still elevated, but one of the great things is you can show a patient a lab. What do we do in cardiology? We say, hey, guess what? You have bad news on your lab. Here's a pill, come back in a year. Well, that would freak me out. They run around, they're typing things into the internet. I have a patient I'm worried about. I have her back in 30 days showing her cytokines and her adrenal curve and how much it's improved. Not only did this lady feel tremendously better, she looked at her future like, oh my God, I was a 52-year-old woman with 2 stents. They told me I was just going to need bypass and technology might get me to 65 and I was just going to live my life on meds. My whole immune system's correcting? Yeah, I mean, you really empowered her. This doesn't happen without fixing the neurotransmitters. The cytokines, even with all of those symptoms she had, those cytokines still normalized in 30 days with her. And that means that risk of plaque rupture has also come under control. I added some theanine. Now, theanine is very good for moving glutamate to GABA. So let me repeat that. Theanine is very good in bringing down the glutamate, but it'll also increase the GABA. So that really did that. I started her on cardiac rehab, maintained the rest of the protocol, and I referred her back to her primary care physician, an outstanding naturopathic physician who was just thrilled. Gender inequality, and that's what we're talking about here today. Tips for practice success. First of all, ask women about mood, insomnia, fatigue during all of your initial intakes and even occasionally after that. And if some of those issues are present, understand that they are telling you that they're at risk for a heart attack. Take that one step further. In some patients, maybe you need to tell them that. If you're like, look, I want to run, panel of tests. I'm going to run this lab and this Boston and this True or whatever, but I also need to get some neurotransmitters too, because I need to look at that serotonin function. I'm going to run your hormones. I really need to do this because I need to protect your heart. Because that's what the science says. That's what circulation said back in 2003, and we didn't listen to that. Question ever lowering cholesterol in women, except for oxidized cholesterol, which is lowered by antioxidants. Run neurotransmitters is a function of inflammation, oxidation, mood, fatigue, and insomnia issues. The only bad cholesterol is oxidized cholesterol, so check it. Use gender-specific cholesterol levels, especially ApoB to ApoA1. Now, right now, the only one I can really claim is the ApoB, ApoA1. Excuse me, the C-reactive protein. It's just publicly known in cardiology that it's about a half point higher for women the scale should be. So I just kind of adjust that in your head. Hopefully, we're going to have more and more scales changing. Please check with your lab to see if they're using gender-specific scales. Stress that women are different than men, and that's a really, really good thing. So they do some neat things here. I'll just kind of tell you my future plans. with the work I'm doing, and a lot of this is I look at all of these types of things in 16 to 35-year-old men who are in refugee camps, as well as ISIS captures. We'll be testing because we're trying to find out a way to socioeconomically empowerment and all that, as well as medically kind of take them from radicalization to a point they can process information. Unfortunately, they always want me to see if I can reprogram people. I can't do that. I attempt to heal people, but I'm looking forward to taking these models that we're discussing and putting them into refugee camps, and we actually already have permission. It's going to look like that our interns and residents are going to be able to rotate in conflict medicine zones, bringing these models of medicine into those conflict zones and actually getting student loan credit back for that. So we've been working on that for a while. The federal government's already approved it. I just got to approve my model, which means I'm going to be spending some time in some dusty tents again pretty soon. And I like this quote. This is Elizabeth Blackwell. She's the first woman medical doctor. And she said, "For what has been done or learned by one class of women becomes by virtue their common womanhood, the property of all women." Please don't keep this information a secret. Dr. Yanez and the team there were lucky. I'm lucky enough to bring this information to you. Let's not stay in 2015. Let's go back to 2003. Bring that information forward. Properly test women as women, empower women, and keep them away from cardiologists. And it's very important that we understand that cardiologists are not going to solve cardiovascular disease. It's going to have to be people who think in a process that we do. If all we're thinking about is, do they have enough blockage to put in a stent, then we're never going to get anywhere. And that's not most cardiologists. Most cardiologists really want to help people, and they want to run echoes, and they do work. They do good work and things. I'm not talking about the character of individuals. I'm talking about the practice of individuals. We are about auto-aggregation and keeping them out of the system. So anyway, I've tried to keep it about 40 minutes here. This presentation is going to be available to anybody, so I know I flew through a lot of these things very quickly, but I'm available for questions here for as long as you possibly want me to be.
Dr. Weiss, thank you so very much. So I do have some questions for you. I'm going to switch screens briefly, though, and put up here a slide where folks can get additional information. Just give me a second as we switch over. Just take a second here. So the first question we had for you was, gosh, there were a bunch of questions. Well, first there was I'm sorry for the loss of your dog, beautiful animal.
Oh, thank you.
So there's a question about testing urine for nutritional deficiencies. Can you speak to that?
Yeah, I don't know a lot about that, and I think that was developed more of in a sort of a multi-level marketed format, is the one that I heard. I think you could indirectly, in my opinion, I think you can indirectly test things like neurotransmitters and products that should be at certain levels, and when they're low, you know that they're going to be, there's probably some cofactors missing. But as far as checking the actual urine to see if they're low in things like iron or magnesium or things like that, I think that the jury's still out. Now, I have to say with magnesium, the latest way people are checking it is in 12-hour and 24-hour urines, even ahead of RBC testing. But at the end, with even magnesium, they don't think any of those methods are very good. You really should use more of a questionnaire and that. So the jury's out on most nutrients specifically. However, I think the neurotransmitter stuff's been laid to rest. I think it's accurate enough.
Okay. There is an interest in, there are a couple questions about AFib and natural approaches to AFib. Can you speak on that?
Yeah. In essence, it's a vagal tone issue. So one of the key things is it depends on the level they're in. Just like with medical doctors, a patient are in and out of it it's much easier for me to get under control. If they've been in it for a long time, it's very hard to get under control. So I always have those same limits. One thing I can tell you is adjusting the hiatal hernia is absolutely one of the main keys. It is largely a nutrient and physical medicine issue. Now, coming up, Dr. Baratovich is going to teach at the Arizona Convention. He's going to be going through some of that stomach manipulation, stuff like that. But from palpitations to fib and flutter, a lot of it I find is a mechanical problem with the vagus nerve where it gets twisted up as it perforates, going from an area of vacuum into an area of that. And then, so that takes in essence, what I do is I look for the problem in vagal tone. It can be cranial sacral. Most of the time for my patients is abdominal, but even when they're having constipation, that's an off vagal tone piece. So you have to correct constipation. So I get a lot of palpitations under control with adjusting a stomach and colon hydrotherapy. And I know that's very contrary to things that you've heard. I think boosting acetylcholine production helps. I think that there's lots of supplements to do that, and I think there's a piece there. I do think biofeedback and getting your parasympathetic tone on is absolutely a major, major part of it. But I find it is largely a physical medicine issue. I hope that helps.
Okay, next questions are about juicing to increase serotonin and other ways of increasing serotonin naturally without medication.
It's largely gut issue, and then as the gut restores, then the brain tends to restore. So when I have patients that are willing to do a juice fast and willing to do those things, and it's really not true juice. I'll do juice with the fiber. I'll have them do, the blended kind of things like that because I really need that big bulk fiber going through there. The fastest way I know how to restore serotonin is 5-HTP, probiotics, and then cleaning out the gut, colon hydrotherapy, juicing, and all that stuff. And then they usually don't need 5-HTP that long. The only thing is you have to be careful about 5-HTP because when they're real low, it can bring it up a little quick. They can have some pretty nasty dreams and nightmares. I don't like tryptophan. I don't use it. I think tryptophan, it does have a potential for firing up some inflammatory pathways, so I don't use it. I'll use a lower dose of 5-HTP. But largely serotonin production, and you always have to worry about high glutamate when they have the low serotonin because that's what will spike too. So I try and do both of those, and I'm a little old school. I'm colon hydrotherapy, probiotics, lots and lots of fiber, and then absolutely making sure they're having, efficient bowel movements. Efficient regular bowel movements is part of that. But it'll come up on its own naturally. With some 5-HTP, it does it faster. And then the last piece is restoring methylation so they can actually manufacture it. So using the activated B vitamins and things like that. So I hope that answers the question.
Thank you. Okay, I've got a few more here. So let's see. There's a question. Do you have the specific ApoB, ApoA1 ratio that you used?
It's in the presentation,
Okay.
and so I do go by that. I don't think that's written in stone yet. In fact, I think the ratio might be a little different for women than it is, but it's in the presentation, which will be available through all the AANMC methods of YouTube and things like that. And if anybody wants me to send that to them directly, just that little square, I'll be glad to.
Okay. Can you speak to any antioxidants specifically for LDL, or are any okay? Are there any favorite antioxidants that you like?
Yeah, well, I'm always an alpha lipoic acid fan. It's medical doctors have argued for years, and they have a point that antioxidants wash out too fast. And alpha lipoic acid takes the high gamma E's and the D3s and the K2s and the Ks, and I use those in combination. So I use like alpha lipoic acid, 300 milligrams, with high gamma E, D, beta carotenes, a little bit of A, K and K2, and I'll use those in a combination twice a day. So everything I use for antioxidants is generally twice a day. Now there's some exceptions. There's some tomato extracts and some lycopene extracts that appear to build up over time, and you can use those once a day. And you'll see those things that are coming out there, but it's a gel cap. It's very specific, but the research is phenomenal on it, lowering oxidized LDL. It's really phenomenal on it. And so I think that the botanicals are going to probably come into better play. But right now, I kind of stick with the fat-soluble antioxidants. I've had really good success. One additional piece to that is the scales vary for the number for ox-LDL. They'll even have it as high as 60 in some of these scales. No way. The data that they drew from ox-LDL was based on the average American. No way. Reversing heart disease and keeping people healthy, it needs to be under 30. So you need and it's nice. I use antioxidants so I get it down there. I can say the other piece of this is when we're starting to look at the way we handle and process antioxidants genetically, there's these tests to look at mitochondrial DNA and things like that. That's probably going to tell us what types of antioxidants people are going to use best, because I do have some people that don't respond to that. But when I have them slather on a glutathione cream twice a day and take some NAC, their ox-LDL drops dramatically. So it is really, there's some genetic individuality there, no doubt about it, about what to use. Again, most of the time, some good fat-soluble antioxidants work, or some lycopene or tomato extract stuff, that'll get under control. But in those other ones, I find that they do need the glutathione cream, sometimes pushes, and things like that. And I'll even mix in some IVs. So stay tuned as we're trying to figure out what antioxidants to use on an individual basis. Unfortunately, I do it a little more in a herd than I'd like to right now, but I generally still use the fat-soluble antioxidants.
Thank you. There's somebody who's interested about the conflict medicine program that you're in. Do you have more information about that?
I'm not in a program. I'm director. We will be looking for fellows in the next couple of years, but I'm a director for Artis International. If you go to artisresearch.com, it's Artis without a T, ARTIS, research.com. That will show you the Center for Health and Medicine, and we have two fellows right now that are in Syria working, surveying ISIS captures, and they're unfortunately within sniper range right now, so we're all keeping our fingers crossed that they're going to be okay. Very, very good researchers, very, very good people. We sit down then at the UN and we sit down with all the warring parties when they have the Syrian peace talks, and we're going to be showing them the information we found that hopefully doesn't have any bias. That's hopefully that we can tell them what's going on with their people. But what's the scary part for me in it is the models of medicine they're using in refugee camps. Antibiotics, antihistamines, steroids, which is largely all that they use. When you look at their patterns, they start to drop their norepinephrine, drop their serotonin, glutamate spike, and then when you measure some of these ISIS captures and some of these guys that are really, really just, their ideas are just very, very difficult to understand, you see very similar patterns. And what's scaring us is that we're finding that the models of refugee medicine we're doing are going to promote radicalization. And we know it does socially, which kind of makes sense. We know it does economically, but medically as well. And unfortunately, a lot of the GMO grains are now making their way into these refugee camps for food. That can't be a good thing, adding glyphosate into these people's lives. But the children are beautiful. They smile and they're wonderful, and I wish everybody there would get a chance to do something like that. So if anybody wants to contact me after this, they can just go to drdeckerweiss.com or just get my email to Joanne. I'm glad to talk about it.
Okay, thank you. Any information on lowering genetically low, how lowering or genetically low cholesterol can lead to cancer from a mechanistic standpoint?
Here's what I can legitimately say, and then I'll give you my opinion. Okay. British Medical Journal came out and said they were trying to, because when they came out with the scathing stuff on statins, I mean, they really went after them. It was right after Lancet said that everybody who has a heart attack should be on statins for 90 days. And BMJ's authors and things, there was a whole big English fuss, because I spent time at Oxford, so I know about English fusses. They can be very fussy, but they're very polite when they do it, and their hair always looks perfect. It's amazing. But British Medical Journal was very, very clear on meta-analysis of all the major studies, including Jupiter, that the lower genetically your cholesterol is, or if it's lowered to a certain point, the higher the risk of cancer. Either way, whether you're lowering it or it's low genetically, you have a higher increase of risk of cancer. We don't have percentages or quintiles or anything like that. Same thing went for dementia. The lower genetically, the more we lower it. Now, the 10-year history of statins, BMJ came out with a little bit later, that pretty scathing stuff. That came about, not that far from Jupiter, which said it doesn't work in women. And then the ductal carcinoma stuff came out, so it's just been a mess. But those are the two things that we can say. Now, here's the other piece. When you reverse the lowering, stop the statin, stop the whatever you're doing, and it rises again, it seems to reverse the risk. And so what I'm asking is, how do we raise cholesterol? Yeah, I know I don't get a lot of accolades and lecture on that, but really with these women with these genetically low cholesterols, I make sure I get as much fish oil into them as I can. I make sure that whatever their products of cholesterol, DHEA and hormones, I make sure those are really, really good, healthy levels. But when women come in with high cholesterol, I'm much less worried about their lifespan than women with low cholesterol. Sorry, I just freaked out about half the audience there. But but that's where the data lies, and that's also where it is. Now, in my opinion, I think statins actually themselves have a cancer effect. I do, and it comes down to also just being a naturopath. When we mess with the liver, and when we're interrupting that HMG-CoA reductase pathway, it's a big pathway, and you're cutting CoQ10 production, and you're jamming up the liver like that, we just see cancer come from that. So I have that naturopathic paradigm aspect. There's data actually on statins themselves causing cancer. It's not as strong as just those numbers, and everybody wants to be politically correct to statin companies, but I do think the statin molecules themselves cause cancer. Now, the last piece of this is what was just approved with no long-term studies, with no risk prevention, as a shot that lowers cholesterol by about 50% for a certain amount of time. It's going to be about $3,000 to $10,000 per year is the therapy. PPSK9 inhibition. To me, the only things that it's really shown is, guess what? More cancer, more neurodegenerative cognitive problems, and they're already doing the same thing. We think it's going to lower cancer or heart attacks by this, this, and this, but we don't have any evidence, but we think that. And I think it's very, very dangerous. They're talking about people who have heart attacks mandatorily getting a shot before they leave. It's almost like a mandatory vaccination. So my patients aren't getting it. The last thing I want after a heart attack is low cholesterol. I want high cholesterol. I want protection of brain. I want fixing of tissues. But I will push glutathione to bring down that oxidation. Glutathione pushes before, or when you think they're having a heart attack, during a heart attack, after a heart attack, is like one of my favorite tools. It just seems to quash that ox-LDL. And there's actually data showing that the next new level we're going to measure for acute MI is glutathione levels. It seems to be one of the best measurements. So with all that, that's my opinion. I hope I was able to elaborate enough on that for you.
Thank you. So there's some interest here in where folks can go if they're not in a licensed state, don't have an ND, or even if they do have an ND, to find NDs who have this type of specialization and understand the neurotransmitter testing and all of that. Do you have any recommendation for locating doctors who would provide this type of care?
I don't, because not a lot of docs are doing this. You seem to see the neurotransmitter folks are just doing mood, fatigue, sleep, and you're seeing them doing that. So I don't have a lot of recommendations for you. I think if you contact the companies that do neurotransmitter functions and neurocardio panels where they blend them, I think you can get some recommendations. But honestly, I would probably try and talk to the local rep of these companies, especially in an unlicensed state. Let me tell you, these lab companies, they love unlicensed states. They love that cash business. And I would probably try and get that rep to comp me a lab or to give me a discount or something and learn it. I will give you my word. If somebody out there wants to learn this and wants me to go through some of these reports from ox-LDL to this stuff, I'll go through with it personally. I don't want this to be a secret. I've made a commitment in my life to change cardiology and a couple other things during my time here. This is the most important information I've ever been to get along, because the majority of women in this planet are women. Majority of the people on this planet are women, and I have 2 daughters, and I don't want them to go into the system. So my commitment to you with this lecture is that if you run a panel and you want me to go through it, I will go through it with you. You can contact me through AANMC or just send me an email, whatever you want to do. And I do that all the time. I do it all the time. I've always felt an obligation to teach. If anybody thinks I'm worth hearing, that to me is a privilege, especially a colleague.
Thank you. Okay, just time for 1 or 2 more questions here. So we have Let's see. What is your reference range for low cholesterol? What do you consider low?
You know, it's I like LDLs for women. And this is my opinion. Okay, I like LDLs for women to be 160 or above, and I like their HDLs to be in the 85 to 100 range. This is ideal. Genetics can largely dictate it, and I don't want it high. Now, again, if they eat sugar all day, these are going to be high because the cholesterol is being produced to protect the tissues from damage from the sugar. So we're not talking about artificially inducing it. We're talking about, where we like it. For men, I think you scale that down. I think the 140 range to 135 range for LDL. Men's HDL doesn't compensate that well. I think if you can get an HDL to 50, that's ideal. Those are those types of numbers that I like. And again, it still is irrelevant. Their ox LDL has to be 30 or less. That's where it should be. So all of that is interesting. It's sort of like a stereo. That's the bass and the treble, but the volume is the oxidized LDL. Think of it this way. When you get one of these heart labs, and it's got 1,000 different things broken down. It's got VLDL, it's got RDL, it's got IDL, ApoB, it's got ratios. All of that's beneficial. Every one of those markers you are seeing has a purpose in the body. There's no bad cholesterol in there. The only bad cholesterol is oxidized cholesterol. That's it. That is the only bad cholesterol. And so patients keep looking good and bad and good and bad, good and bad. And I've met, you want to spend a really long, as my friend Dr. Holly Lucille says, it's not a boardroom, it's the really boardroom. I try and steal as many things from Holly as I can. I spent a few days with Cleveland Clinic lipidologists. At the end of the day, it was oxidation and inflammation all day long. They told me volumes about all the products, all of these individual pieces. And I was like, why do you call LDL cholesterol bad? And they're like, well, it's not, but we do that for education purposes. For education purposes, that's like, let's make sure that socket has electricity for education purposes. Let's stick a fork in it. I mean, education purposes. OXLDL. So again, that's all fluff and it's interesting, but the OXLDL is the marker that's the important one.
Okay, last question. So students wanting to learn more about this, where would you recommend that they go to understand what you've discussed today a bit better?
If you want to learn about, there's something called an NEI curriculum. It's not as third party as we like, so I don't want to really say where to get it, but if you type in NEI curriculum, it's through one of the lab companies, and they do a nice job at going through the HPA axis, neurotransmitter function, and where that all fits in. Eventually, I think I'd like to write a chapter for them dealing with heart disease, and we've talked about that. But I think to learn HPA axis function, because students, you're going to be intimately involved with HPA axis, and that is a great simple way. You get a nice little certificate. Students need certificates on their walls. We all did, and it never made me any taller. I need to get a few more certificates. Leave it alone, Dr. Pianos. Leave it alone, right? But I think that that's a good place to get a broad base of information, and I think that there's enough really good stuff there that gets you off to a good start. Some really good infographic stuff that works well to educate you as well.
Thank you so much, Dr. Weiss. I really appreciate your time today. And with that, we're going to conclude the AANMC webinar. We've gone a few minutes over time. Our apologies for that. Again, thank you all for coming. The recording will be available on our YouTube channel and at aanmc.org/videos in about a week. Thank you again. And as you can see, we have some upcoming events. AANMC's virtual fair for prospective students is March 8th. This is an opportunity for students to meet with staff and students and alumni from the accredited naturopathic colleges in North America from the comfort of your home, so you don't even have to go anywhere. And then April 5th, we have a webinar about naturopathic approaches to anxiety and depression featuring Dr. Keffer Butts, who is a Canadian resident in British Vancouver, BC. And as always, for more information, please contact info@aanmc.org. We're happy to help you out. My apologies, we did not get to all the questions today, but if you email Dr. Weiss, as he said, for those of you who had specific questions related to cases, I know that he is always happy to help folks learn. So Again, thank you all for coming. Dr. Weiss, thank you so much for taking the time today. And with all, I hope you have a great rest of your day.